Good afternoon. Good afternoon, everybody, and welcome to the Hounslow Health and Wellbeing Board. Just before we kick off with introductions, I wanted to remind you all that we are actually being recorded, and I also wanted to welcome those that might be joining online. So, a quick round of introductions. I'm Councillor Lily Bath. I chair this meeting because my portfolio responsibility is adult social care, public health, and health integration. So if I move to my right, thank you.
I'm Jane Medici. I'm the clerk for this meeting.
Afternoon, I'm Stephen Forbes. I'm the Executive Director for Children's and Adult Services here at the Council and also currently responsible for housing services as well.
Hi, I'm Chris Hilton. I am the Chief Operating Officer at West London Trust and here representing the mental health and community provider in Hounslow.
Hi, Amit Gupta, Hounslow Borough Medical Director.
Ben Tomlinson, Head of Housing Planning Resources with the Council, here to talk about the housing strategy.
Alfie Barishi, Assistant Service Manager for Housing Partnerships, also here to talk about the housing strategy.
Claire Gomes, Senior Strategist from the Public Health Team and responsible for the substance misuse agenda.
Hi everyone, my name is Dan Rogers. I'm the CEO of Public Voice. We've recently taken on the Health Watch Hounslow service.
Peter Goulding, Chair of the Local Health Watch Committee. Very good afternoon.
Good afternoon, Sanjay Krishnamurthy. I am the Medical Director at West Middlesex University Hospital.
Hi everyone, I'm Councillor Samia Chaudhry, Cabinet Member for Education, Children's Employment Skills.
I'm Councillor Sue Sampson, Lead Member for Housing and Homelessness.
Martin Waddington, Director of Health and Care Integration for the Council and for the North West London ICB.
Thank you, everybody, for the introductions. So I'm going to move on to the next item on the agenda, and that is election of new members of the board, and we need to sort of formally agree. So we've got two that will be joining us. I'd like to welcome Dr. Sanjay Krishnamurthy. You're the Medical Director at West Middlesex Hospital. Did you just want to say a few words to introduce yourself? I know you have.
Yes, I'm happy to. I'm a consultant in acute internal medicine, was previously the Clinical Director for Urgent and Emergency Care Services, and as of October last year, was appointed into the role of Medical Director at West Middlesex University Hospital. So very much from an organizational point of view, starting to look at what we can try and do and affect health populations across Hounslow, much more than just looking at what we're doing internally.
Thank you very much. That's lovely, and we look forward to working with you on the board. We also want to elect Dan Rogers, and Dan, you'll probably get a chance to introduce yourself when you do your report. So if I can ask everybody if they formally agree to elect two new board members, is that formally agreed? Perfect. Thank you very much. Okay, then we will then move on to the agenda item, which is minutes of the last meeting. So what I propose to do is, I'm hoping you read through the minutes of the last meeting. So if I can just check from pages 7 to 13, anything that relates to accuracy first? Any sort of inaccurate details? No? Okay. In that case, I'll record them as accurate minutes of last meeting. And then if we can move on to matters arising. So if we do page 7 first, are there any matters arising on there? No? Page 8. Page 9. I am just looking at the actions column, and I think all of the actions are complete, apart from the letter to the Minister of Health. That's still ongoing. So I'm looking towards Stephen, and is that in process or? Okay. Yeah, I think I did see an email, but I think it's probably got. Yes, it's on pause somewhere. Okay, but apart from that, action 2, We'll probably talk about that in the health and wellbeing report later on. We'll touch on area forums. And then Sue was going to talk about, she was going to promote 50 things to do before you're 5 with a housing newsletter. That's done. Brilliant. Excellent. Well done. Thank you. Then nothing on page 9, page 10. Can't see anything. Just shout if there is anything that you notice. Page 11. I can't see any actions on there. And then page 12, nothing. And page 13, any matters arising from those? No? Okay, perfect. Okay, if we then move on to the housing strategy, we've got Ben here and Alfie. They're going to present, they've got some slides, they're going to present the housing strategy, which is out for consultation. We've got Councillor Sue Sampson as well, who's the cabinet portfolio lead in this area. So we're really wanting to think about housing in the health and wellbeing context here. So if I'll let you present, are you going to both do together or?
Yes, thanks, Chair. So I'll do most of speaking. I will defer to Alfie in some areas that he's more of a involved with. I think Alfie's going to negotiate the presentation.
Okay, so we've got about 30 minutes on this item, just so that you're
so I'll aim to get through in about 10 minutes and then take
Okay.
any questions and feedback from the panel, if that's okay, Chair.
Yep, lovely. Thank you.
Great, thanks. So for those who may or not be aware, the housing strategy is actually a statutory responsibility on the local authority that covers off a number of areas. So we have a statutory duty every 5 years or periodically to consider housing need in the borough to ensure that we have every plan and means of, available at our disposal to meet it. We have but basically to do a similar exercise around homelessness, and housing is a very live area of policy in government at the moment. There are plans afoot with specific relevance to the Health and Wellbeing Board to introduce a duty on local housing authorities to also plan for supported accommodation in their area. So that's something that everybody should be aware of. How we basically go about it is we do a big sort of data collection area exercise that looks at everything: council management information data, flows of homeless cases, housing stock in the borough in particular, in terms of planning applications, what's in development, what's not. We go forward and then basically in looking at all that data, come up with what the need is in the borough in terms of the housing requirements and go through it. So it combines the statutory housing strategy that we need to do every 5 years, the rough sleeping and homelessness strategy, which is a separate strategic requirement. We basically look at the data that underpins those areas in terms of demographic data, market data in terms of the housing market, and come up with what we believe the gap to be. It's then the job of the housing strategy to address how we can best fill those gaps, noting that the local authority is very constrained in terms of its funding. There is an escalating pressures outside, both in terms of public health needs, aging population, and also the funding constraints and the economic situation in the borough, which makes housing unaffordable for the vast majority of our residents, whether they're renting or looking to buy. So the main statutory responsibility of local authority as it stands, not factoring in the soon to be added duty to ensure that there's sufficient supported housing in the borough, is preventing and assessing homelessness. That's not just the sharp end where it's rough sleeping, but also in general households that may be vulnerable than average, who become homeless due to being unable to afford their accommodation, or the landlord asking them to move out for a multitude of reasons. So we have to ensure that we manage safely our own council stock. You'll be aware of the tragic case of Ishaq Awab, the young child who died due to damp and mold in the property. That's a big concern in the council stock. We also have a duty to provide universal housing options and advice. So anyone who presents themselves to the council, we're required to give them advice on where they can best find a house, regardless of whether we in fact have the duty to put them in temporary accommodation because we believe they're vulnerable. There is within the planning directorate, there is a private sector housing enforcement team whose job it is to tackle housing that's below legal standards, health and safety risks in the private rented sector in the borough. That would include private registered providers of social housing. So we have an enforcement role. And then obviously at the very sharp end, where people in sort of from a general practice background would probably encounter it, is helping out rough sleepers in the borough, many of whom may have substance misuse, substance dependency issues, and a whole bunch of comorbidities. So you'd be able to grasp that better than I could, but we do need to look at a long-term sustainable pathway for those people, helping vulnerable people, which includes care leavers, people who have disabilities or older ages, in general, ensuring that as best as possible we can meet everyone's housing needs. So in terms of the timeline, we started off internal consultation within the council back in October. We have run workshops with colleagues pretty much across all the council's departments, just to check that when we went out to formal consultation, we weren't going to say anything at odds with what people's lived experience was operationally, what they perceived as the challenges amongst our colleagues. We took the feedback from that to our cabinet in April, I believe. So it was maybe just earlier this month, and it was approved for us to go out to formal consultation. So at the moment, we are out for a formal public consultation exercise for a period of 6 weeks, which is what's brought us here to this board, really to receive feedback, comments from medical professionals and suitable representatives across the borough, just so that we can factor that into our housing strategy. So the consultation will run, I think it's slightly delayed start, so it's going to end the very beginning of June now, but it's on the council website. And then any feedback commentary that we receive, we will factor into a final version of the housing strategy to be presented to cabinet in July 2025. So very briefly, some of the things that we know already. So obviously the grey wave that's going on in the borough. We know that there's going to be a lot of elderly people. The number of very old people is increasing, and that means that you need to provide certain types of housing for them. There is population growth in general, and whilst in the previous few years the increasing number of the housing stock vaguely kept in line with that, that's unlikely to be the case in the future. All sorts of developers are struggling to provide additional units due to inflation. So there is also sorry, Alfie, can you read that? Bring it up. So sorry, I'm struggling to read this, but in general, we know that sort of the aging population, an increased number of people with disability, and also problems with people dropping out of education and employment during the pandemic harmed the social situation in the borough. So in general, housing's got more expensive. There's greater demand on housing that's suitable for disabled people, for elderly people, and the population's growing. So background of escalating need in the borough, whereas we know conversely with the properties, the stock's aging, there's not going to be any massive increases in the number of housing stock. The wages have, people in the borough have increased fractionally compared to the commensurate increase in the rents during the same time. And a lot of people in the borough will be living in damp, cold accommodation, which we have limited means to remediate. So that's just into the background. In terms of homelessness, our own cases, we saw basically a trebling of rough sleeping, homeless approaches in the borough over the lifetime of the previous strategy. So in spite of delivering a lot of extra units in housing and being quite successful in a number of areas, the homeless approaches from families being thrown out of their accommodation and rough sleepers in the borough trebled between 2018 and 2024, sorry. And we know that one of the things that we need to do better is sort of work at upstream prevention. Quite often people don't present themselves to the council until it's the moment of crisis. So we know that we need to do more about prevention. Some input from yourselves on what that might look like would be appreciated. We have some ideas, but again, everything's sort of constrained with money. Again, we know that the background of need across the borough of rough sleeping comorbidities with mental health there, substance misuse. It's a big problem. We've just seen not only more of the same, but more of the sort of an intensifying of people's problems. They tend to come with us with the whole package of things, and no sign of that trend easing off, unfortunately. So basically, our draft ambitions, as they stood at the point of sending out the strategy: reduce homelessness, tackle rough sleeping and its consequences, secure additional high-quality, safe, green, and affordable housing, improve the quality and livability of existing homes and estates, both within our own stock and the private sector, support residents to live independently, promote their health and well-being. So that very much ties into the objectives of this committee, and also tackle crime and ASB on estates, encourage social and economic inclusion. There aren't significant problems with, say, gangs and stuff in Hounslow, but it is probably an escalating area compared to what it has been previously. I mean, we're not our estates aren't bad compared to some of the other landlords around London, but it is a probably area of increasing pressure that we're aligned to. Another thing that we have to notice from the local authorities' point of view, the housing strategy must align to our local plan. So in terms of the development plans for the borough, the spatial planning element, we have to make sure that we're not proposing anything that's at odds with the development that's planned, the types of development that we set out we need in the local plan, and that we align to that, so that people at planning committee can't raise any objections over it. And that would include, for example, things like section 106s or SIL requirements that ensure that we're building new hospitals, primary care facilities, education facilities, things like that. So there's a dotted line to the local plan, which would cover over some things you may be familiar with like that. So with that said, that's a quick overview of where we've come from on the housing strategy, what our responsibilities are, and the kind of things that we've thought about. Any comments through you, Chair, please, if anybody would like to give us any feedback, it'd be greatly appreciated.
Thank you very much, Ben. Before we sort of kick off with questions, Councillor Sampson, did you want to add anything at all? No? No? Okay. All right. Thank you very much. Sorry? You're strategied out, yeah. Okay. Just to say thank you very much, Ben. That's very helpful. You've sort of outlined the challenges and your duties here. So obviously big challenges here. Any questions from the board here at all? Anything they want to feedback? I have some, but I'll take questions from the board first. Chris.
Thanks. And just wanted to say thanks and welcome the opportunity to contribute as part of your consultation. I've written to colleagues within the Mental Health Trust to see if we can share any of the data about the impact of housing and housing related issues for our patients with you as part of that consultation. One of the things that, from my clinical experience, that I observe is often individuals who are in a grey area between being formally homeless and yet not being able to be discharged home, and either because they have domestic issues, or in some cases injunctions against returning to their home, or their home isn't deemed to be fit for habitation. So anything that we can do together that helps us identify solutions to support people to have a place to stay that also allows us to discharge them from a health setting to make way for the next one would be really, really welcome. I don't necessarily expect you to answer that now, but we can share some.
No, so just for our notes, sorry, Chris, that would be like nominal bed blockers in a hospital or other setting.
So I particularly probably avoid using the word bed blocker probably, but in mental health settings and in the acute hospital settings, and also in the emergency department, we often have patients who are but for a perceived housing need, and that might be their perception or ours, are unable to be discharged. So
their accommodation's not suitable, but there's no clinical need
or they believe they're unable to return to it, sometimes for relationship reasons or other
right. So it could be less of a, because we'd immediately assume that it's a physical requirement of the property that's not being met. I don't think we'd we're not so geared up to explore people's interpersonal relationships.
No,
but that's a very interesting point.
It is, but from our perspective, and Sanjay probably agree, we've got a number of patients in both the mental health trust and in the acute hospital settings who are defined as clinically ready for discharge, but are unable to be discharged, or we don't feel confident discharging them in some circumstances because of their social situation. And it's labelled as housing, but often we find that they don't meet a technical definition of homelessness.
Right.
So there's a sort of grey group that I think would be really helpful.
So they'd have a home to go to, but they would be in need of housing options and advice in order to navigate them to suitable accommodation.
Happy to pick up outside how we kind of conceptualize and quantify.
Yeah, and within the bounds of GDPR, any sort of data you could give us to flesh that out, some examples would be really useful. Thanks, because we can use that to hone our services. Thank you, Chair.
Thank you. That's a really important question there. I'm thinking of the hospital social work team, and I don't, Stephen, is there anything you want to add to that?
So it was just to kind of piggyback on what Chris was saying. I think it is labelled as housing. I think I would say it is the right accommodation with the right support that matters, particularly for, I think, in the domain that we have a joint interest in mental health. So I think that's a bit we do need to probably explore, Ben, outside here with Martin and commissioners about how we, and providers about how we get the right accommodation and the right support in the right place at the right time. Too many rights there, I think. But those 4 rights are the right thing to do. I think then it's also just reflecting, I think it's a good point in terms of the living independently, to reflect on the decision that Cabinet made. I think now two Cabinet meetings passed to commit to the development of 180 units of extra care housing. I think that does begin to address, as Ben's rightly identified, that ever-growing population of older people. And again, I think just looking to Sanjay, and it's not dissimilar from mental health provider, but acute medical and the work that we do around about frailty, is that isn't 180 units of the same thing. And I think we've already started a bit of a conversation about what's the future need. And it's, again, the right accommodation with the right support in the right place. And I think we do need to have a bit of a combined bit of work here between the housing strategy and the adult social care intentions about making sure we get the right provision, because these buildings will be with us for 30 or 40 years and they're serving a potential future need over the next 15 to 20 years. So we need to do a little bit of planning, I think, in the strategic space to say it's not just, as we've said before, rolling out the next version of Bristol Court. It's potentially something different, and particularly where we see, I think, in the frailty population, an increasing age population well into their 90s with a huge level of comorbidity and increasing frailty and dementia and behaviours that challenge, all being wrapped up together with a potential much higher need of nursing support as part of the right support in the right accommodation. So I think there's a bit of detailed work we need to do, picking up Councillor Sampson's statement, to strategise ourselves even further out to get that detail right.
Thank you. So good conversation there. So I think you've got a bit of a plan and some work to do around there. Any other questions? Dr. Sanjay.
Thank you. Just one other aspect in terms of knitting together different parts, and I wonder whether there is an opportunity, especially with the homeless population, whether we can try and knit together drugs and alcohol teams. So we have quite a high proportion of of individuals who are homeless who have drugs and alcohol problems, and it is a potential opportunity, irrespective of where they enter into the system, to try and bring those 2 parts together as well.
Do you feel that there's under provision at the moment, Doctor? Is that something that you're seeing not being addressed, or is it that we're trying to address it but not meeting patients' requirements?
So I think the challenge you have is you have essentially two cohorts of patients. So a majority of these patients need ongoing care, ongoing correspondence. And with the homeless population, it is very difficult to get them to regularly engage, because not least because we're not able to correspond with them in manners in which we do currently. So I think drugs and alcohol in individuals who have stable accommodation get a very good service. I would say drugs and alcohol in individuals who do not have stable accommodation or are homeless are very, very vulnerable.
So that would be reinforcing the housing first model, where we look to accommodate people as a priority and then plug them into the services that they require. Thanks.
I think I'll bring in Claire here. 'Cause right opportunity for you.
I'm usually loud enough and I didn't think about that, sorry. Yeah, there's a couple of different things that are going on at the moment. So in terms of the people who are obviously have already been in the hospital in A&E or been admitted, the alcohol care team is in situ, and I think the work between the alcohol care team, psychiatric liaison team, and actually now the housing officers that we do have in the hospital has been strengthened enormously over the last 12 months, and the adult social care team. So I think, thinking about Chris's point, actually, we just need to strengthen all those teams that are in the hospital further, because usually the people we're working with have got several of those issues, not drugs and alcohol on its own. It's very common. There's multiple comorbidities and social issues. So I think that's along the right tracks, and we just need to make sure everybody's brought together in the teams that are in that hospital. Outside of the hospital. So I think if somebody's come through that route, I think they're followed up really well now. But outside of the hospital, what we do have is within the rough sleepers team in the council, there is one drug and alcohol specific worker, which isn't within my portfolio. There's separate within housing, but they are linked really closely with ARC. And we have an outreach worker in ARC that will often also add to that and go out with them. We've recently set up a sort of pilot, although we're absolutely intending to carry on in Trinity in terms of a homeless health hub. And so that's not necessarily everybody who's street homeless, there's other people popping in there as well. And the ARC workers there every Thursday. So there are things progressing. I think the gap actually and the struggle is sometimes when people are in temporary accommodation. People who are street homeless, I think we're probably doing a little bit better with. It's people in temporary accommodation, and Ben and I have talked about this lots of times, and we absolutely have a drive to work more closely together to make sure that we're identifying people, because if they're identified we can support them, but that might be an area where we're not always identifying people well enough.
Noted. Thank you, Doctor and Claire. We'll take those back.
Thank you. So it sounds like you've got all the teams there within the hospital. It's just about the communicating and getting that right. Okay. Councillor Sampson.
No, I just wanted to raise the point that of the conversations we've had recently, and that's regarding street homeless that really don't want to be helped. How can we help those people when they don't want it? You know, it's very distressing, upsetting to see. That is certainly like in-depth conversations we're having at the minute as well. That how do we work with that? How do we address that?
I think we've all tried, Councillor. Everybody's been involved in the housing sector. I know you've tried. I've tried. There's people that I can think of immediately when you mentioned that some people just don't wish to be helped. They feel they're living their best life and wish to continue down a path that is deleterious to their health, to say the least. But it is very difficult. If people would like to give us some advice on that, Mr. Forbes, Chair.
He's got the answer to everything today. There you go.
I mean, I think it's because I think you picked up, and again, it's I think a shared agenda here. We're talking about it in accommodation, but I think it's across the NHS and social care, and we've had a number of cases over the last couple of weeks, particularly around about discharge processes, where they are what I think we had a trend before the pandemic of talking about people who used to fall through the cracks, and they are classic of those people who are, for the want of a better description, resistant, non-engaging, but actually we've got huge concerns about what happens for them. And to use a word that I was using at a summit earlier on today, it's the stickability factor. So we might not be able to do anything for them at the present time, but we don't close the door, we don't turn away, and we keep track. And we've got one at the moment, I think that Sandy and I would probably know, we have no idea where this individual was between January 25th and when she presented at West Mids. She looks like she's got capacity. She's making some very difficult decisions, very oppositional decisions. But actually I feel, and I think we all feel, very hesitant to say, well, there's nothing we can do. And we can't just, in essence, put her on the street outside West Mids Hospital and hope for the best. But she is not engaging. And that's the kind of person, I think it's not just accommodation that deals with that. It's the whole system has to say, these are individuals that we tag and flag and we stick with them. Because if not, there is a risk, as Councillor Sampson says, what happens? And I think the public expect more from us than just saying they resisted and we closed the door.
Claire.
I think the one thing that we're trying to do through the project around the homeless health work is just make sure that at least we're giving people harm reduction in whatever that may be. So not necessarily just drugs and alcohol, but addressing some of the primary healthcare needs that they might want addressing. So we've had some people that have just wanted to have glasses because they actually haven't had an eye test, and we're trying to meet them where they are. So yeah, in terms of the night shelter, when we had that at Trinity and put the homeless health hub in place, you're absolutely right. Of course, there are some people who didn't want to stay in, but if we can still offer them something, even if they pop in for something to eat and we can do something meaningful, I think that's critical. And it's that engagement. We've had one lady that the engagement tool has been that she will be very keen if we can offer her some tomato soup. It really is, it sounds ridiculous, but that's actually, and eventually we did get her the care that she needed. And actually she was somebody that did not need drug and alcohol support and inpatient support, but it took multiple attempts and we had to be quite creative with what the hook was. So I think it's, as Stephen said, it's that not giving up, opening the door. But if we can reduce harm, even if somebody doesn't want to stay in, then I think that's our objective.
Yes, Sue, go.
I think the health hubs, I know we got one at Trinity, but is that not something that we could spread throughout the borough? Because I'm thinking of a particular, well, 3 people actually that are predominantly based in the Bedfont and Feltham area. They're not going to walk all the way to Hounslow to just access that. But if it's on their doorstep, I think we've got more of a chance of engaging, or them people engaging with that. If it's on the doorstep as such. I was just wondering if it's something that we could look at spreading right throughout the borough.
Yeah, I mean, we completely agree. We're sort of trying to prove a concept at the moment. We don't have additional funding for this, so it's trying to bring partners together. And of course, you know, we're all trying to use the same resources. So absolutely, I think when we will be doing a review of this with the Rough Sleepers team, we're working, somebody in my team, Martin's team, and the Rough Sleepers team are working really closely together. So I think once that report's written about what we've been able to do so far, early days, but that's absolutely what we would like. It's just obviously trying to bring the resources together and ask for people to put those posts in. We've not put anything additional in it. It's really been drawing people to a central hub.
Thank you. Can I just ask a general question about the quality of housing? So obviously we know that has an impact on health, and I'm sort of referring, I suppose, not just private sector, but you know, all housing. And I think you mentioned damp and mold, didn't you, earlier on, Ben? And I know it's a bit of a challenge. What specific measures have we got in place, and particularly private as well, because that is a little bit of an area that is quite difficult, isn't it,
So I think
to get right?
It is a complex and wicked problem, councillor, as you know. So the issue of damp and cold homes is driven by a number of things: lack of insulation, old housing stock with you know, cavity walls and gaps everywhere, but also sort of the heating systems that are in place. And whilst it's a tiny minority of the housing stock in the borough that's actually so irredeemably bad that it can't be brought to have no damp and mold. What drives the greatest volume of cases is sadly people that feel they're unable to afford to heat their home. So it's more of a economic issue and challenge than a building structural challenge. I would suggest in the first instance there are bad homes, and yes, you can always improve insulation, improve the energy efficiency, and in theory reduce heating bills. But on the face of it, first and foremost, I'd say that it's households that are struggling to prioritise heating costs in the winter that are dealing with damp and mold, or households that are overcrowded that are dealing with trying to dry laundry indoors because they've got no outside space, or things like that, but without a lot of money to purchase dehumidifiers to keep the heating cranked up all day that would remove some of the damp in the atmosphere. So first and foremost, it is probably an economic problem that as we see it, although the council does take strict enforcement action on people that don't meet the minimum health and safety rating standards. Sorry, Councillor.
I was a bit more concerned about the private sector really, because I'm aware that obviously a lot of people now relying on the private sector for their housing needs, and you know, not all of it, but there is a significant amount that is not in a good state. So particularly where there's overcrowding as well, so that will have an impact on health, won't it?
So
Yeah.
yes, the Renters' Rights Bill coming in later in the year, Council will give us more powers to deal with private rented sector. We do have powers at the moment, but only where it's a breach of the health and safety regulations. So if it was a category 1 hazard, if we felt it was so damaging to people's health, we could intervene. But there is likely to be a decent home standard brought in for the private sector. The Renters' Rights Bills, I think, still at committee stage in the House of Lords at the moment, and it's not actually in the legislation going to codify standards for the private sector. It will empower, I believe, a new regulator for the private rented sector that will be constituted and then issue guidance, statutory guidance as to what the standards in the private rented sector would be. And we will have powers, I believe, under that bill once it becomes an act to address those. So it's going to be a very different picture if you ask us in 12 months, and the housing strategy will certainly address that and the preparations that we're making for that as a council.
Did you want to? Yeah, okay, that's good. Okay, I think I don't have any more questions from anyone. No, in that case, I think I'll wrap up. But yeah, no, we've had a good discussion, and thank you very much for the presentation. It'd be interesting for you to come back in 12 months' time as well. Yeah. Given we've just talked about the Renters' Right Bill, because obviously that will have implications.
Thanks very much, Joe. Yes, we'd love to come back if you're able to invite us, and we can update the committee on the final housing strategy.
Just before we leave, is there any particular actions that we need to capture? I think we're all on the same page, but I think we're just a little bit. We talked a little bit about sort of working together a little bit more. I think really from what we're saying. Yeah.
We'll pick up outside between commissioning our department and housing the issues in common with health and acute about accommodation and support. I think we do need to address that, and I think we can do it across acute, frailty and mental health. It's the same concept, just a different flavour. So we'll sort that out outside.
Okay, great, thank you very much, Ben.
Thanks very much, Chair.
You're welcome to leave if you want to, or you're welcome
yes,
to stay.
if we may be excused, we've got some work to go on with. Thanks.
Yeah, I'm sure you've got all those things to do. Thank you very much. Okay, so we will now move on to Hounslow Health Watch update. So all right, Peter, over to you, Peter.
Chair, thank you very much indeed. I'm the chair of the local committee of Health Watch. We've had some substantial changes, so I'd like to put this into 2 parts, really. Just a very, very quick overview from myself in a couple of minutes, if that, and then hand over to Dan Rogers, who will give you a presentation about the new host organisation that has taken over Hounslow Health Watch as of the 31st of March. So I am a local resident. I chair the local committee. We are made up of local people, either that they live in the area or they work in health or social care. And we are still members as a active committee. We were working under the previous host organisation, Your Health and Social Care, up until the 31st of March. That's now transitioned over to Dan under the new organisation. He will explain that in a second. We would normally give you an update from time to time. There is a Q4 patient experience survey report that will be published very shortly. We will circulate that, and we can give a more in-depth presentation if you wish at our next meeting. That sort of concludes all the work from the previous host organisation. The one outstanding matter that we are working on now is our annual report. That will be published very shortly. We will, of course, circulate it. So if I could now, Chair, with your support.
Before we pass over to Dan, can we just, on behalf of the committee, thank you for your hard work, Peter. I know you'll still remain on the committee, but you've been a great advocate for residents, and you've been very committed over the past few years. So thank you very much for that. And obviously you'll be staying on the board, but and if you can update us if there's anything that's relating to previous actions, that will be really helpful as well. But yeah, I'd like to introduce Dan. Yeah.
Thank you, Chair.
Thank you very much, Chair, and I'd like to thank the board for inviting me to speak today. So, as has been mentioned already, Public Voice has taken on the role of managing the Health Watch Hounslow service as of the 31st of March. I wanted to kind of talk a little bit about who we are and introduce ourselves to key stakeholders in the borough, and also our vision for Health Watch Hounslow and the work that we're going to be doing. So just in terms of Public Voice, our mission as an organisation overall is to translate the insights and needs of people into actions to improve services. And we want to contribute to reduced inequalities and improved outcomes for communities. And the way that we do that is through broadly 3 different types of work or activities. We seek to engage and understand stakeholders. That can be service providers and commissioners, as well as residents, communities, service users, and with a particular emphasis on seldom heard groups and creating equity in terms of engagement. That often then feeds into the second area, which is creating productive discussions between commissioners and providers of services and communities, eliciting kind of insights and having kind of productive dialogue to identify changes, improvements. And then the third area of work is where we get involved in supporting the design or delivery of either improved services or new activities and interventions. And I'll talk a little bit about some examples of what those look like. So in terms of engagement, obviously that's a fundamental aspect of the work of Health Watch. We've been delivering Health Watch services effectively since the inception of Health Watch in Haringey since 2013. We deliver also in Croydon since 2023. Our work has been commended for the kind of the evidence-based and outcome-focused approach, which is critical to our work. By Health Watch England, we've been commended in Health Watch Awards, and we contribute to wider Health Watch England and Care Quality Commission funded projects in order to try and influence policy and practice on a wider scale. But really the focus of our work is about identifying priorities and issues, engaging communities, gathering evidence, but then also working with stakeholders to act on recommendations and to implement change. So for us, it's the end point is not publishing a piece of research, it's working with stakeholders on what happens next. In terms of then productive dialogue, we also seek to kind of support co-production approach and involvement of residents, and that can be in a number of different ways. An example is we run a joint partnership board, which was launched with Haringey Council in 2017. And the board ensures that vulnerable groups have a voice in the way that health services and social care services are provided for them. So effectively, we run a series of forums for different groups to co-produce priorities with providers and commissioners and decision makers, and identify areas for change, and then they work together on making those changes. And then as an example of the third area, we get involved working with the voluntary and community sector, for instance, on developing new interventions and helping. So another example of our work in this space is something called Reach and Connect, which is a service for socially isolated people at risk of social isolation or experiencing social isolation who are over 50. And effectively, we go out and meet people on their terms. We co-produce with them on what their plans are for and how to address some of their needs, and then we empower them to do so. So these are just to give you an example of the kind of different ways in which we would seek to intervene and support the improvement of services. And our work is based on experience of engaging across a variety of different boroughs and in different contexts. So as a further example, we have a neighbourhood service that provides independent resident advice to tenants and leaseholders living on social housing estates that are going through the process of regeneration. And at the moment, we work in 6 different London boroughs. And the reason I mention that is because, as I said, we work in different contexts with different demographics. And from that, we've developed kind of methods of community engagement that feed into how we then deliver services like Health Watch. And that in turn then will often lead to working on other pieces of of work or projects where we can try to influence change. So further examples of discrete projects that we've delivered off the back of those experiences include working with demographics who are experiencing have worse outcomes and experiences of maternity services in Haringey, helping the Croydon to map its voluntary community and faith sector to identify gaps and opportunities for more targeted funding of health and wellbeing services in the borough, and developing a health champions network in Waltham Forest. So again, I give these as a very brief kind of introduction to the types of work we do, and therefore the types of principles and that will guide our work for Healthwatch in Hounslow. So our vision for Healthwatch Hounslow is that we want to, as I said, we're developing a kind of consortium of high-performing local health watch based on an evidence-based approach and an outcome-focused approach. We work regularly with teams to undertake the Healthwatch Quality Framework. For those of you not familiar, that's a regular process set by Healthwatch England to self-assess the performance of the Healthwatch service, identify actions for improvement, and undertake those improvements for a continuous improvement approach. We have established local Healthwatch in other boroughs as a key stakeholder in local health and social care decision making, and we'd like to maintain or advance that in Hounslow as well. And we've helped communities and place leaders to engage residents and embed participation, involvement, or indeed co-production where possible in services and commissioning. In Hounslow, our intent is to support community co-production and involvement, particularly in Healthwatch Hounslow's priorities and work. That will be working with and through the committee that I'm pleased to say has transferred over and will be continuing to work with us. We'll provide systems and resources to complement the local service. So we have central resources and expertise in, for instance, communications. So there will be, we believe, kind of more regular, active engagement and communications across the borough and across different stakeholders to let people know what Healthwatch does and what it can help individual residents or community groups with. And we also have an information signposting team, trained information and signposting team, who can provide information, signposting, and where necessary, advocacy to support individual residents. And again, this is something we'll be actively promoting across the borough and encouraging people to contact us where they need help. We'll share learnings, tools, and best practice for our outcomes-focused and evidence-based approach, based on our experience of delivering research projects. So there's robust methods behind the work that we do. And we'll seek to expand Healthwatch Hounslow's influence and work with local decision makers in and beyond this room. And doing that through kind of developing, we want to do that. We'll want to go and visit and understand some of the services that have been delivered, as well as working with the wider voluntary and community sector who have a significant role to play in interventions and support for health and wellbeing. And we're doing that already across the borough in terms of engaging or re-engaging key stakeholders. And on that note, would very much welcome opportunities to speak with individuals around this table, and of course any recommendations of other contacts to speak with as we re-engage, as I said. Just in terms of the team and the structure, so as I mentioned, there will be a core Healthwatch Hounslow team. We're pleased that the pre-existing manager Asta has transferred as part of the service. We've then been recruiting to add to that team, and we were successful in finding a research and engagement officer through interviews last week that will be adding to the team shortly. We provide the supporting functions that I mentioned so that the core team can focus on engagement and research. And then we provide a structure for the local committee to define local priorities and to use and that decision making will be based on a broader range of kind of evidence and insights from the kind of community engagement and work that we do. And in turn, that also has a link to the Public Voice Board. So we have a subcommittee of the Public Voice Board in which our local Healthwatch leaders meet and talk about kind of issues that may expand across beyond individual boroughs. And then briefly, I just wanted to kind of share some of the topics that have been coming up from the conversations we've been having over the mobilisation process over the past couple of months as we've transferred the service. We've also been out talking to people and key stakeholders, reviewing strategies, etc., to understand topics that might be a kind of focus for the year ahead. As you can probably gather, our preference is to not only do ongoing engagement and gathering of views, but also then to use that to identify specific topics where we'll do deep dive research and seek to kind of recommend and support change. Some of the examples of the projects or project ideas that we've identified through recent conversations include the experience of asylum seekers and recent migrants in terms of health and access and experience of health and social care services, autism services, the rollout and expansion of Pharmacy First, and children and young people's oral health. This is by no means a list set in stone. It's a prompt because we'd very much encourage other ideas and suggestions, which we would then channel through our commissioner as part of the service. So please do let us know if there's other topics you think we should be thinking about for the coming 6 months or so. And as I said, we'll also be planning a series of outreach and engagement events over the next few months to either engage or re-engage stakeholders. And we've been talking, for instance, with the Ealing and Hounslow CVS about doing that. And again, if there are opportunities to do that with stakeholders at the table or others, please do let us know, and we'd be happy to engage. So that was just a brief summary of who we are, what we want to do with Health Watch Hounslow, and where we are in terms of defining our work. And Chair would welcome any questions or suggestions.
Thank you very much, Dan, for your presentation. Yeah, I think I'm going to bring Martin in now before we take questions.
Thank you, Chair. Thank you, Dan. So first, we'd like to welcome Dan to Hounslow and his team. The Commissioner is my team, so the Joint Commission team led on the Commission. There was really a good field, so it was a very well-challenged and well-won contract. We've started the induction. I think the most important part of the next 6 months isn't to ask Dan and the team to do lots of things, but to meet all the key stakeholders, the residents, the population, and understand Hounslow. So my big ask for you all is don't give him tasks straight away. Tell him about Hounslow, introduce him to your teams, make him understand Hounslow well, and then maybe come back here with his first thoughts to ensure that what we do really makes a difference to Hounslow. So, you know, and I think that's where the Health and Wellbeing Board is really critical, to make sure we engage with him as part of our system and really help him understand what we require.
Thank you, Martin. Chris?
Thanks. You know, congratulations on winning the contract. It'd be useful to know the length of the contract as well, so that we can form that relationship and get you to know really well all of the services that my organisation provides. I completely agree with Martin that we need to. You're very welcome to come and visit any of the West London Trust community, adults, children's, and mental health services that we've got in the borough. And we've been in touch with Eamon, who's introduced me to Ashla to try and set up some of those induction meetings. As an organisation, we operate in Hounslow, but also in Hammersmith and Fulham and Ealing, and we have a relationship as well with the outgoing provider. Including a contract for them to continue reaching into some of our Hounslow services for a further year. So it'd be really good to kind of think through some of the sensitivities of that, so that, but also to avoid duplication as well, and so that you can learn with them anything that we do really well in our neighbouring boroughs that we should be doing better here, and vice versa. So something for us to pick up outside.
Anybody else? No? So Dan, just couple of quick points. I know you this is obviously early stages and you're going around and you're learning about the borough, but you did pick up some priority areas, didn't you? I just wondered how you sort of decided on those.
Yeah, thank you, Chair. So we've, as I said, over the kind of in the run up to mobilising the contract, we've had a kind of a roughly 2-month mobilisation period, and during that time, we've been having conversations with stakeholders already, and as part of that, we've been identifying what sort of topics are there, either in strategic work or particular current initiatives, or things that we're hearing from community groups, etc., that would be potentially priorities to take forward. As Martin's quite rightly said, we're continuing that process over the coming months, particularly with the engagement, re-engagement events, and kind of one-to-one activities, visiting stakeholders, locations, facilities, etc. So that's not a final list by any means. It's just to give you a sense of 2 things. Firstly, some of the stuff we're hearing to date, which is a move and feast in terms of what that list is going to look like over the kind of next few months. And secondly, to just illustrate that our intention would be to identify important themes through a range of sources and extensive outreach, and then to prioritize some deep dive research topics.
Okay, thank you. I mean, I wondered if it is worth you coming to our area forums. Yeah, if you could, because they are a good place where you'll meet, a number of residents, and you'll hear all different kind of stories and challenges and concerns. So yeah.
Thank you, Chair. And we've actually started to attend those, or I attend those, because we're also supporting the review of the strategy, the health wellbeing strategy, and supporting that work. So very keen to go and do that more if that is a requirement, especially from the area forums.
So thank you, Dan. I don't think we've got any other questions, but obviously you'll be coming to our next committee, and we'll hear a little bit more about what's been going on and what feedback you're getting from the engagement. I understand you've got to go, so we'll let you go. Okay, thank you very much.
That's great. Thanks very
Yeah.
much, and nice to meet you all.
Thank you. Okay, so we will now move on to Claire, is that correct? Who is from the Drugs and Alcohol Project within the council, just going to give us an update on where we are in terms of the progress that we've made and some of our indicators. So I'll pass you over to Claire, and actually you've got a presentation. It's page 38 on the agenda. Yeah, thank you.
Thank you. I'll just wait for it. Is it going to load up? Right. I think I last came to the board perhaps 2 years ago, maybe a little bit longer, when Harm to Hope, the National Drug Strategy, had not long been released. So some of you will have heard some of the beginning of this before, but I think we felt it would be useful to hear where we've moved to over the last 3 years. So apologies for anybody that this is a little repeat of, but the new government's National Drug Strategy was released December 2021. That was after 2 really lengthy, substantial reviews of everything around drugs, particularly because we'd had a year-on-year rise in the number of drug-related deaths in the country by Dame Carol Black. The strategy, when it was released, had 3 main aims. So overarching aims are to make sure that we improve our treatment and recovery system and the offer in terms of the quality for all areas in the country, that we also reduce the demand for drugs, so the prevention agenda to be prioritised. And then the last priority was around breaking the drug supply chain, so looking at enforcement and that link between the criminal justice system and drug treatment. So along with the drug strategy, fortunately, came a new drug treatment grant, which it was called the Supplemental, I'm going to try to say the Supplemental Substance Misuse Treatment and Recovery Grant, so the SSMTRG. So we had an announcement that would be given to all local authorities across 3 years, and we're coming towards, well, we've just finished the 3rd year of receiving that grant. At the same time, we were asked to set up partnership boards within local authorities to make sure that we're bringing all of our partners together to look at drugs and alcohol as a whole, which is chaired for us by Stephen Forbes. So that's now been in place since 2022. So we've got on the slide there the amounts that are given to Hounslow in terms of our SSMTRG grant. And I think that actually, just thinking in terms of the context of the other discussions tonight, one thing to note is that some areas, including Hillingdon and Ealing, also receive a specialist rough sleepers drug and alcohol grant. So it's interesting working across with partners who see other areas, and the size of the teams that they have, they will be different because we've all been given very different amounts of money to provide these services. So for example, in Hillingdon, the rough sleepers grant is almost as much on top of what we receive for our whole treatment grant. So it's just a point to note that restricts us in terms of activities a little. However, it was very positively received funding for us. So the final year of the funding, as you can see there, was just over £760,000. And that's come with some specific targets. So as a country, the government wanted us to increase the numbers of people coming into treatment, the adult population, sorry, by 20%, the young people's population by 50%, and also to improve continuity of care, which is the number of people coming from prison who've got a treatment need into community treatment services. So in terms of Hounslow's targets and where we are now, because of the national drug treatment system that we all utilise, the latest figures won't be end of year yet. So hence we've got the December figures there. So we're not quite at the end of the year to compare where we are with our target. But you'll see there, in terms of our baseline, we were at just over 1,000 adults in treatment, and we have to move up to just over 1,200. We're not too far off that as of December 2024. And I've broken down the different groups just to look at the specifics. So we're just 6 people under target for our opiate cohort, up to 14 for our alcohol cohort. So we're talking about small numbers. And in terms of our trajectory in Hounslow compared to regional trajectories, we've actually often been in the top 3 in terms of increasing that number of adults into treatment. The young peoples, we've moved up to 70 young people, but there's a little work to do there. I think we work between high power community service and the YOS workers. And I think one of the key things there is to do a little bit more work around people understanding how to use the data better. It seems we have a lot of young people who are being given one-to-one support, who could come onto that formal system. I think something to note with this is that this is all about people in structured treatment, and our services work with a lot of other people who don't want to come into structured treatment as such. They might not agree to a care plan, but we will do brief interventions with them, harm reduction initiatives, and they don't get counted in these formal figures. So there's a lot more that goes on around the edges of this work. In terms of continuity of care, the December figure was a bit of a dip for us. We have been top in London. It's quite specifically because of some issues at Wormwood Scrubs in terms of administration. So actually what we do is a monthly audit of cases, and that number will go up because actually those have all been revised. There were just some administration issues. That means we'll be back up to the top with continuity of care. So just a brief in terms of what that SSMTRG has been used for. So the biggest need for us was to employ more staff. But in terms of the look of those staff roles, it's really quite varied. So we needed criminal justice workers to make sure that we are working with those people coming through from prisons and also from the probation system and courts. But also we've employed people specifically to run groups in the service, because actually the recovery workers have got really large caseloads, and we know that people need one-to-one work and groups. And then something I'll talk a little bit more about in a slide coming up is staff to step up a new recovery day programme. Aside from the staffing, we now have something in the borough called BOB. So BOB stands for Build on Belief, and that is a charitable organisation that's run entirely by people who have lived experience. And this really was off the back of listening to our service users. So we ran several listening events last year, and we are in regular contact with our service users. And what people told us is that for those people who are really struggling, they need somewhere to go at the weekends, and we didn't have weekend services. So Bob has stepped up a full programme of groups. And something to note is that for anybody working with people who aren't in treatment, Bob is for anybody. So they don't have to be in ARC. Anybody with a drug or alcohol issue could come along in a weekend and drop into our group programme. And then the grant has also paid for things that we need in terms of consumables. So things like Buvidal, which is a little bit like a depot in mental health terms. It's a long-acting version of methadone. So that's been really important for those people who struggle the most to clinically with methadone and other things like that. I won't go into this now. That's just for the board to look at another time. That's an example of our Bob programme, but it's continuously changing depending on feedback from people who are using the programme. Okay, so just a couple of highlights from the things that we have funded through the grant. We stepped up a Recovery Day programme. So a Recovery Day programme for us has been amazing for Hounslow. It's almost an alternative to rehab in the community. So there are a small minority of people that rehab is absolutely what they need. They need to go out of the borough. But for others, actually coming to something more substantial than ad hoc appointments in the community has been really beneficial. And talking about the alcohol care team earlier, actually this has been a fantastic route from people coming from hospital who really need something quite substantial in place. And actually that's a lot of people have come through into the Recovery Day programme. So the Recovery Day programme's 5 days a week, overseen by a psychologist, but with an awful lot of input from our service user. You'll see in a minute the timetable that's been revised, which has been very much co-produced between service users and staff. And the team involves a person who has lived experience as well as one of the paid posts, which is the service users have told us is one of the most important elements rather than a clinical input. So because it gives them hope that they can also achieve recovery. So since the Recovery Day programme started, we've had 201 service users access it. And they're the 41%, apologies, official completion rate is a lot higher than rehab. But actually, what that doesn't show is for some people, they don't get to the end of it because they go on to employment, paid employment. And actually for them, that's okay that they don't get to the end of the 12 weeks. Of course, there are some people that relapse because that's part of addictions, and we'll pull them back through to the core ARC service. And again, sorry, this is going to be very small on the screen, but just so that people see an example of the sort of timetable. This is the latest timetable, the sorts of activities that take place, and just an invitation to the board that if anybody would like to ever come along to one of the graduations on a Friday, people are always really keen to have other people, outside people there. So in terms of things that haven't been funded through the grant but have been stepped up through this period since we last came to this board, as I mentioned, we now have the partnership board, which has increased visibility of the agenda. We've produced recovery films listening to our service users about stories that they have to tell, which have also been shared broadly. And I think it was early last year, we came to talk to our members and got our service users to come and tell their stories. So in terms of that increased visibility of the agenda, that's been one of our key priorities. We also now have, everywhere in London now has a police adder team, which is a specific team to link criminal justice services and our local Met policing with the treatment services to try to divert people who are committing crime and antisocial behaviour, but it's driven by their drug and alcohol use, into our treatment services. One thing that is new is our Hounslow Heroes team. So that is entirely made up of our service users, and their main initial remit has been to get naloxone, which is the opiate reversal drug, out in the community. And actually the first quarter that they were out and about training people to use naloxone, I think we went from an average of around 50 naloxone units being given out to over 300. So that's been a fantastic project. But actually they're not just doing that, they're out there talking to people about recovery, what drug and alcohol treatment is, and being real advocates for our service. And I think I could have used a whole slot on this. I think some of you have heard before about our alcohol care team. So I'm very grateful that the alcohol care team was funded jointly by the borough-based partnership 3 years ago. I think it was the first project funded by the Barrow-based partnership. We have a 5-person multidisciplinary team. So we're not just employing nurses, we have nurses, recovery workers, and somebody with lived experience in the team. And in terms of the work that the team has done in the hospital, I think the results speak for themselves. We've been recognised as good practice by OHID, and this model's been used as a gold standard model and shared with other teams, other areas, around the region. And actually, I'm doing a presentation about this at the OHID London Forum in a few weeks' time. So one of the main aims is to, of course, get people out of hospital into community services. And I think when we've had teams like this in place before, they've done a brilliant job of screening people in hospital, which for some people, if their alcohol use is quite low level, that's a prevention measure and that's fantastic. But that 5-person team and that multidisciplinary team has allowed people to really do that assertive follow-up in the community. Some people don't want to come into treatment straight away. They may have 5 conversations, 6 meetings outside of the treatment system and outside of the hospital before they're willing to come to ARC. What we've seen in terms of the numbers, and really grateful to our West Mid colleagues because this project wouldn't have happened without Dr. Emma Rowlandson. What we've seen is over 56% decrease in readmissions for alcohol-specific admissions within 30 days. And for me, as a Commissioner of the Drug Service, one of the most important things I've seen is nearly 400 people in those 2 years coming through to structured treatment through this project, which is really quite significant. Another very minor point, I won't stay on this one too long, but we're the first service in the country to retain Hep C microelimination, which we were the first to do it for a year, and now we're the first to do it for 2 years. And again, it's been joint working with our hospital colleagues, our hepatology team, and the charity Hep C Later. So we've got a whole systems approach in terms of making sure that bloodborne viruses and harm reduction is talked about from day one with our treatment service users, and that we're making sure that we get those people through to treatment, because there's an awful lot of stigma around hepatitis C and the treatment it would involve. And actually the team have done an amazing job, also thanks to the hospital team, at achieving that microelimination in service. And just briefly, we have just commissioned CNWL again to continue to provide ARC and HYPE, the Young People's Service. So I'm happy to take any questions about any changes. They are minimal because the model's been working very well. One thing that is a positive is we will have 1 additional Young People's worker. We found it really difficult to do one-to-one work, the schools prevention work, and the hidden harm work, so supporting the children of parents with drug and alcohol problems. So that has been increased. We have had to have a slight reduction in outreach posts because the budget didn't allow for all of the posts that we required. However, we do have some outreach work. And also, I think the importance of partnership work is the most prominent thing here, because we do have some great outreach workers in our rough sleepers team, within the community safety team. And so we're just trying to make sure that we're as joined up as possible with those other services. So that's the grant for the last 3 years. We now have a new name for the grant, although it looks entirely the same for us. So when I mentioned before that some areas have a rough sleepers specific grant, what the government have done is brought the grant streams together. So we have now got one grant called the DATRIG, but for us in Hounslow, it looks exactly the same. It's a new acronym. It's exactly the same amount for us in 24-25. We're waiting for an announcement of a 2-year funding agreement. Around June was the suggested date. So we're waiting to hear whether that will continue at this level or change, which will obviously let our partners know. And I think the only difference really with the new grant and the requirements is that we still have exactly the same targets before. So there's still some targets around getting more people into treatment, but actually the government's asking us to report on the outcomes in terms of whether people are making sustainable progress in treatment. Actually, for us in Hounslow, you'll see there we're already well above any of the regional averages for those outcomes that we're being asked to measure, and it's something as a commissioner I would measure anyway. So we're quite happy with that introduction, because it's always a balance between numbers and quality. And finally, I think, very briefly, in terms of our new DATRIG, we've also been asked to produce a word plan, not just a plan of what we're spending the money on. So looking at our priorities, I've just mentioned we've got a new service. So although it's the same provider, there's some bedding in to do there. We're still being asked to increase numbers in treatment, but particularly around the opiate numbers. That's a national requirement, and the young people in treatment. We will be, hopefully very soon, opening a new recovery hub in Oxley House in Hounslow, which for us will be really an important shift, because when I talked about Bob before, there's a lot more they can do in a separate building, and also in terms of a group programme and all that service user work through Hounslow Heroes, we'll have a space for those people to be away from the clinical service across the road at Montagu. So that should be coming soon. We've begun a drug and alcohol related death panel, and so we'll be looking at the learnings from that. Some interesting learnings already around comorbidities, as you might expect, and a crossover with mental health, and the learnings from our suicide panel. So that will continue to be a priority this year. Service user involvement. Actually, our contract this year, I won't be just looking at KPIs. Twice a year, included in my contract monitoring, will be to go and talk to our service users and have listening events, because I think that's really important, and to make sure that we have good representation on our board. Tackling stigma, because if we don't do that, people don't come to treatment unless they're absolutely desperate. And lastly, we want to really carry on improving our joint working with our local Met colleagues, because we feel that there's a lot more that we can do together to bring people into treatment and away from the criminal justice system. And then that is a very brief summary of what the grant is paying for this year, which is very similar to last year because the amount is the same. So it's largely around staffing. There'll be some slight differences where we've chosen to bring some key roles into the core contract with the opportunity through commissioning. Yeah, and we will also have one last thing. A new thing will be a small recovery grant. So wanting to make sure that our work with our service users isn't tokenistic. They have some really important things to say to us, and we want to make sure that they're able to think of some projects that would actually improve our services, and we'll be putting a process in around that and bringing those ideas to the board. So I think that's about that. So any questions?
Thank you very much, Claire. Very good presentation, and interesting to see that we're going in the right direction. Some really good outcomes there. I know, Stephen, you chair the partnership board. Did you want to say something as well? Yeah. I will bring Councillor Sampson, but I don't know if you wanted to add to that. No.
Never miss an opportunity, Chair. I mean, I just think I say this is one of our good news stories. And I think it's that classic thing that you often hear me talking about, is it's not something we can point to and you can take a photograph of, but there's some really good stuff here happening for people who are at the end of, some very difficult life experiences and in the midst of despair. And that's why I think the hope bit really counts here. And particularly the stuff that's done through the lived experience and the user involvement and the weekend stuff. I mean, that's really, really good stuff. It's purposeful, it's meaningful, and it's hopeful. And I think we just need to continue. Picking up what Claire said, we cannot ignore, and I think if you reflect back to that session we had here with the users from ARC, that issue of stigma still is there. It is something that particularly is problematic for people who need to access these services. And I think particularly in Hounslow and some of our sub-communities, it's a bigger issue. So it is okay to come forward and say you have a need. You shouldn't feel that you can't. So I think we do need to see what we can do this year. I think finally, my bit is, I as the chair of the partnership board take no credit whatsoever for the good work and the good outcomes here. Claire needs, thank you. Claire needs recognition. Without her passion and enthusiasm, much of what we've done as a system would not happen. She is a bit of a one-woman go-getter on this and pushes it forward, and then encourages and inspires a lot of other people in the system to do their best as well. And I think finally, probably looking at the three of you as elected members, when we do have the new venue opening up, again, in that beating down the stigma, being open about it, I think it would be really good as the members of the Health and Wellbeing Board, if you were there on that day to basically acknowledge that, because I think it sends the right message to people. and particularly because it's a user-led offer there as well, which I think says the right thing. It's not a service-led offer, it's a user-led offer. So that's all I would say. That was enough.
Stephen, yeah, no, we'd be more than happy to visit the new hub. That would be great. And yeah, I do feel the passion from Claire, and well done for all the work that you've done. I'm going to bring in Councillor Sampson.
Can we just go back a slide?
Yes, this one. Or
Because
yep.
I was quite surprised to see just such few workers and such great outcomes. You know, I was quite astonished at that, because for what you deliver, I thought there'd be a lot more people involved.
There are a lot more people involved. This is just the grant funding, because we were reporting on the drug strategy and the grant that came with it, and they need to step up the board. This is just the specifics. A few slides back, there is a full staffing, although there's a couple of changes, there's a still full staffing organogram.
Right. Okay.
Yeah, no, there is. And as I say, I have to mention people like the one person in the Rough Sleepers team, brilliant joint working, and they're kind of part of the team. We wouldn't do it without those other posts, peripheral posts, and the YOS young people's workers too. So yeah, these are our additional we've been able to fund, and it's important to note as well, because we don't know whether we're going to continue to get that funding. So
you've got to.
We'll find out in June. So fingers crossed.
But can I just ask one slight question, different question as well? The ACT and the ARC, what is the waiting times for people to be able to access that service?
ACT and ARC.
Yeah.
So ACT is purely opportunistic in a hospital. So they're based in a hospital. So obviously they're seeing people on the wards well, and also working with our hospital colleagues to make sure that they're upskilled enough to bring people to them on the wards. So that's different. That was a.
They access via A&E.
Yes.
Okay.
Although more than just A&E, actually, although most of the work's in A&E, there is more done in the other wards, and even with they do ambulatory detoxes and all sorts of different ways. So that's a bit different, because it's an immediate response, where we previously had quite an opportunity gap, if you like, of people who wouldn't have come to treatment necessarily. ARC, we have to get people into treatment. We still have targets of 3 weeks, and we meet those targets. It's not necessarily very easy. What we can do is we can offer somebody a one-to-one sort of assessment and a conversation. It's the clinical need that's a little tricky, because obviously the people who need to come through for prescribing, it's the doctor's element of the service. So one of the things we found, that with all this great work and the targets, we've got all these people coming to treatment, but the opiate users, because they need that element, that's been quite a challenge. So one of the things that's been stepped up this year is that CNWL have managed to have an agreement with a university, and I'm going to forget which one, so I'm not going to say it here, to have trainee posts. So we have an addiction psychiatrist, and we're going to now have a trainee underneath them who will also be able to do that, some of that prescribing, because we do struggle with that element, and that's where you could end up getting the blockages. But what we do around that is use all of our other posts and our peer support workers and all that sort of thing to at least have conversations with people. And the other thing that we'll be starting once we open Oxley, we haven't had the physical space to do this, but we're going to just start slowly with one open access session a week. So it will be a drop-in that anybody or a professional with somebody who's not in treatment can come in and bring them in, and that will help with this access, but also for people who maybe don't want to come to treatment yet. We can again do that harm reduction and just build some relationships with them. So yeah, that pretty much as soon as we've got the new building, we can utilise some space to do that.
Thank you. I want to bring in Councillor Chowdhury.
Thank you so much, Claire. I just wanted to say well done to yourself and the team, and especially I think it was a year ago when we had the open day at ARC, how successful it was, and especially to the team members who have been standing at the square, giving awareness to people. I think it was really, really great. And so thank you to them on behalf of us as well. Thank you.
Thank you so much. And yeah, to note that my thanks to ARC and our services as well. They do a difficult job.
Thank you, Peter.
Continuing the thanks to Claire, but also the wider team, because it's the whole team, isn't it?
Absolutely. Yeah.
Is just in reflection, is there something that we might be able to build upon here? We've got a very good model that's working really well and engaging. Still got lots of problems, lots of challenges. So is there something that, how do we move that model across, that way of working, that integration into other areas? We talked about housing earlier. I'm not being critical. I'm just saying we built a model that seems to have worked quite well. Lots of integration across different services. Is there a way in which we can try and educate, help other areas to see whether they can adopt a similar sort of philosophy or a model? Is there some learning that we might be able to take, and how we might be able to do that?
Thank you, Claire. You did actually mention, didn't you, earlier on in your presentation, that got good joint working, but it could be better. So I don't know whether it's something you could sort of reflect.
Yeah, of course. And I think in terms of good practice, in my role, we have a London Commissioners Forum and an England Commissioners Forum. So there's lots of good practice shared. Obviously, everyone has really different levels of resources. So we have to take that into account in terms of whatever can be achieved. But I think, as I said, I'm sharing the alcohol care team model because of that integration and just the fact that the model's a little bit different to most areas models at the London Commissioners Forum, and that's been shared broadly. So I think it's a work in progress for all of us, and we're very willing to take on that good practice from other areas too. And in terms of applying it to other services, I know that, for example, people in Martin's team looking at some of those other hospital services, we've worked together around using similar features to the alcohol care team model. So I think we're doing that, but there's always more to do.
Martin?
Thank you for that, Peter. I guess one of the successes of Claire's team is the partnership. So she does have a strong partnership with housing, a strong partnership with Westmead, a strong partner with social care. They could all get better, and we had a long conversation about, how people have to do their job so much that being able to go and have a conversation about something that quite isn't their job is still a struggle of resource. But I think one of the things we are building on in Hounslow is, and Claire's service is a demonstration of that, but I wouldn't like you to think she's doing that alone. It is in partnership with Sanjay and the team and housing and the team. So I think we are learning from that as a system together already.
Thank you, Martin. And as members, we're always happy to do our bit, in terms of breaking down sort of barriers and stigma and stuff like that.
Yeah,
and having that training that we had some time back, I found that very useful, actually. Yeah. So more of that would be welcome. But thank you very. Stephen's got his hand up.
So it's coming back to what Peter said. I would say there's always an opportunity to learn. But what I'll go back to is where I started off when I spoke about this is good news. What we are not good at in Hounslow is talking about our good news. We just don't do it enough. And so, I'm sitting here looking at Sanjay thinking, we've got this broadly round about Westmeads and the frailty stuff, and there's huge stuff we need to do there, but we've worked really hard over the last 3 years. The fact that Sanjay's sitting with us today, I think, is one of the positives about the relationship. And actually, we've got it. What we're not good at in Hounslow is actually stopping for 5 minutes and saying, what we're doing there is really, really good stuff. And others do that. So there's a little bit about, we wouldn't have had this if Claire hadn't thought that actually we do need to update where we're at with the drug and alcohol thing, because it's relevant. And I think we need to get better at every now and again. And the Health and Wellbeing Board is probably the place for that, of structuring things to come back here that actually say, in this area, with this patient group, with this community group, whatever, we're doing good stuff. What's the opportunities for that to be learning elsewhere? But let's acknowledge that in lots of other Spanish, just a cut has come to us. Back again. Cut off in my prime. I think we need to just get better here at saying, yep, we're doing really good stuff here. In frailty stuff and hospital discharge, we're doing really good stuff. And, I'm sitting here thinking in adolescent stuff, we're doing some really good stuff. In youth crime, we've got one of the lowest rates of repeat offending and numbers of new entrants, and yet we don't talk about it enough. So there is a Hounslow habit of not talking ourselves up, and I think we need to get out of that in this world, particularly when funding is a bit short, new ideas are always welcome. We need to shout a little bit harder about the efforts that lots of people put into it.
I totally agree, and that helps people who are on the front line in various services, because they need to be congratulated and they need to hear other good news and pick up issues and say, oh, if I go and speak to somebody over there, they've got similar problems, they are working better than me, what can I learn? You know, that would.
Sorry, I got a bit distracted there from somebody walking out of the room. But yeah, just before we move on, Claire, thank you very much. I just wanted to, not on a negative note, this is not negative, and I totally agree with Steve, we need to celebrate what we do. Is there any sort of future changes in NHS that might affect the work that you do at all?
I think one thing that affects our work is any social changes at all. So cost of living, etc. Unfortunately, more people tend to end up with mental health issues, turning to alcohol particularly. So our demand goes up and the complexity goes up. And what we are finding at the moment is we've got a group of older patients with more and more complex health problems. So that's a challenge. And obviously the criminal justice changes impact our service a lot as well. But at the moment, as I say, I think everybody in my sector is waiting to hear whether we continue to get these grants. So that's really key, and what that level of funding will look like. And I have made a plea to OHID around that rough sleepers grant element too, because I looked at how it was funded and how it was decided who gets what, and I feel that we have a good case to make. So I think it's we stretch that grant a long way. So it's a combination of those external factors and that grant funding. So we shall wait and see.
Thank you very much. I don't have any other questions, and thank you very much for your hard work, and we look forward to you coming back again and sharing your future sort of progress as well. Thank you. We'll then move on to the next item on the agenda, which is the health and wellbeing strategy update. Martin, you got a...
I wasn't planning on clicking, but let's see what. Yeah. No, there isn't. Just any other business.
Good
There we go,
try,
Chair.
Martin.
It's done.
Good try.
Thank you very much, Chair. So, as you know, in March 2024, we agreed that we'd have a new governance framework that would hold the board to account for our priorities, and then we do this report on a quarterly basis. So this is a report for quarter 3. At times the board makes suggestions of areas that we do a deep dive. We haven't done one today because of Claire's presentation was seen as a priority. So I hope you've all read the report. I'm not going to go through it in detail. Clearly what the board's always interested is the red ones. The current red one is around support in maternity and tobacco reduction. We've really struggled between the public health team and the tobacco team in West Mid. We've really struggled to engage on that. As we're all pleased, Sanjay is now a member of the board, so I'll take you away as an action that I'll work with Sanjay to see how we can engage with staff and take that forward. I wouldn't recommend that's a deep dive at the moment because it is about staff engaging and getting a programme of work together. Other than that, following Stephen's view that we should celebrate more as well as dig into things that aren't working, we're looking for suggestions for the next board. So that is the only red one. So if it's up to the board, would you like to do a deep dive in any of these areas, or would you like a bit of a celebration of some of the good things that are happening? It is open to you.
Councillor Chowdhury?
I think it's been really, really, really good, Martin. Thank you very much for this. I think all the greens and ambers is good to see. But with obviously with speaking to the pregnant women and with the new mums about quitting smoking, I know it's a challenge. It is a great challenge for hospital and our public health team. Have we thought about is that we can do something different to start off with when they kind of arrive for their first antenatal appointment or something? I don't know what the process is there. I know the team must have been like kind of giving them leaflets how to give up smoking and just kind of explaining them what's good for their health. But currently, I'm not sure what the process is. Is it just if someone wants to take it on, they'll take the service on? And if for example, we've got 80% females saying no, what else do we do?
So clearly we do a lot around stopping smoking as well as work with the hospital. This real target is about encouraging women who are pregnant to stop smoking. And as I say, it's been a problem with engaging with the West Mid team. There is some training in place, councillor. So it's called very brief action training to encourage frontline staff to train, to encourage people who are smokers to stop. So as far as I'm concerned, we know what we need to do. It's just making it happen is the issue. If you're keen to have more on what we're doing around stop smoking, we could have that as a theme at future board.
You volunteer.
Thank you.
Thank you. But it's up to the board what they want to decide.
Oh, are you? Oh, okay. Oh, so you're the champion, championing. Just before I bring Peter in, I wanted to ask Dr. Sanjay, is West Middlesex non-smoking outside? So I'm just thinking about. Sorry, if I raised a sore point here, because some hospitals are, aren't they? So if we're trying to encourage, stop smoking maternity.
So we are non-smoking outside ostensibly. It is, as you can imagine, a very difficult aspect to enforce, but we're trying to do other things in that we're trying to look at areas where if individuals want to smoke, that there are enclosures to smoke in rather than and we're extending that to vaping as well. So we're trying to move away from that, what you see of people standing outside the front door of the hospital smoking. There is quite an active smoking cessation service which runs within the hospital. I know it is part of the antenatal first appointment, but clearly we need to be doing more. And Martin, I welcome that. But happy to engage.
Okay, thank you. So Martin, you're looking for ideas for deep dive, really? Is that what you're saying? Yeah.
Yeah, we said we'd hold ourselves to account. I think we've now got this very clear dashboard. It's completely up to the board. If there's areas you're concerned about, some of the amber ones, we could look at that. If there's, we don't have to do things, we're busy, so we don't have to do things if for no good reason. But I think a good bit of celebration is always a good thing. So having people come and explain the good work we've done to get to green may be helpful. You don't have to, people could just contact me and Kelly or Anne and people for the next meeting.
Yeah, I mean, it'd be good to celebrate and to do a deep dive, wouldn't it, really? Two things in conjunction, but I don't know. I'll leave it to the board. Yeah.
I think it's really good to celebrate it at this point, and we see what happens after 3 months with amber ones, if everyone agrees to it. Because it is a good celebration on this to see green ambers, and sometimes ambers are just there where we are about to reach our target, and they will go green anyway by the end of next, the quarter performance report ending.
Stephen?
In essence, I can't resist myself. I do think some of the amber areas, and one of my favourite areas is early years, the readiness for school. This is not something that's going away. And it's got their project experience and delays. I'm not quite sure what that is. So I think that's a conversation outside, but this is an issue for us in Hounslow. And it's back to, my trip around the area forums about putting the emphasis on that being really critical and a generational step change for this population. And I think we need to have if there's anything, to have a deep dive, and it's not about it being critical, because this is a really hard thing to crack, but it's exposing it again, having the discussion, having that debate, and working out what we need to do about it, because it's insipid in our population, and we need to tackle it. It leads to long-term, I'm going on my soapbox here, I can hear myself. It leads to long-term social, economic, and health disadvantage. And if there's anything we can do as a public body is to stop and turn that around. This is the area we need to have a bit of focus at.
I think we hear you, and given its long-term impact and the fact that you can have a big influence at an early age if successful. Obviously, it's really important. But yeah, okay, Peter.
Thank you, Chair. Frailty was the other thing that crossed my mind. Lots of people in the room know the real details, so much work going on. But of course, there is an audience that listens to this as a board, because it is a meeting that we do circulate, etc. So it may well be useful to say what we're doing at an appropriate point, and now might not be an appropriate point. I just put a marker.
Stephen, do you want to respond?
So I was actually going to suggest, because we are preparing to go live with our test and the PCN and the 5 GP practices and care and health integration in September. And I think that is something, if we get to the point by July that we have signed that off as the senior officers to go live with that it is relevant we come and talk about that here, because that is about trying to change the experience of frailty and how we operate. So I think that would, not a deep dive off this, but I think we would have intended, I think Martin and I would have been having a conversation with Chris and Ben, Programme Director, to say we need to come and talk about it here, because you're right, Peter, we all know it because we spend an awful lot of time talking about it, but I think here in the public domain we need to have that conversation.
Okay, sounds like we've got a plan then. Yeah. Okay. Anything else you wanted to add, Martin?
The only thing, so that's the current strategy. I know a few of you have been going to the area forums to work on the future strategy, and wondered if any of you wanted to update on how that has been going.
Yeah, I mean, the ones that I went to, I thought was really, really good. I mean, it's good to hear a sort of wide, sort of diverse range of views, isn't it? And some people are quite, public about they're quite opinionated about things that they're not happy about. But the interesting thing is it makes you look at health and well-being in a wider context, doesn't it? So for some people it's about being able to go out or feeling safe when they go out, and maybe they're not moving around much because they don't feel as safe. Or for some people it's not having access to sort of services like GP services. For other people it's other things. So in that sense it's been interesting. Yeah, I think it's a really good initiative, and I think we should definitely carry on with it. I think we've done all of them. You've done all of them now, haven't we? Yeah.
Yes, I was just going to say, I think it was very useful because we had the sessions before the formal area meeting where people could go and talk, share, exchange ideas, give opinions, etc. And I think that was very useful.
Thank you. I think that's it. I think we've got the next item on the agenda is Better Care Fund, isn't it? Yeah, it's you again.
Thank you, Chair. So items 9 and 10 are all the Better Care Fund, so I'll do them all as one. So as you all know, and if you don't, you haven't been listening for the last 13 years, but Better Care Fund is a joint fund between the council and the health system to ensure better discharge and supporting people in the community from discharge. On a quarterly basis, we do a national return that we have to send to NHS England. So item 10 is Q3 return, which Councillor Bath always signs off as the chair of the Health and Wellbeing Board because the timeframes are out of sync. So she has signed this off, so it's really just for your approval and questions. And then item 9 is our planning for 24-25. As you probably all know, in March of this year, the government decided that the future of NHS England was in doubt, and also with that came the news that the ICB would need to make 50% reductions. That really caused some troubles over the planning period, and I'd like to thank Stephen and the council for that, because the ICB then, and I'm speaking from an ICB position at the moment, so the ICB needed to find some savings out of the Better Care Fund. That has put great pressure on the councils across North West London. Luckily, Hounslow were in a position to make adjustments and sign the forward plan. So again, I don't think there'll be any questions on the full plan, but I do think for a future meeting we need to update you all on the changes to the future of the NHS when the guidance from governments come out and is more clear, and we need to update you on the changes we'll be making to the Better Care Fund because of these financial challenges. But for today, I would just like us to approve the forward planning document, and that's it.
Okay. Thank you, Martin. So can I ask that you all formally approve or have any questions beforehand or comments? Stephen?
So a comment, because I will have to slightly disagree with Martin here. From my perspective, the request of the ask of the savings in the Better Care Fund are not at all related to the announcements by the Health Secretary to the changes to the ICB. That is about the ICB's staffing structure. These changes, or this ask, originated, from my perspective, from the running deficit that the ICB has in North West London, and that's been well known for over 2 years. And I am less than happy, as much as I've been acting in a very calm way, that we were asked to deliver this 4.5 days before the planning submission date, when we've been actively engaged in a review process for over 14 months. So the reason we did not submit, because that's a bit Martin didn't quite say it, I will say it, we did not submit our plan on the specified submission date. We were at least a week behind that because of that slight glitch. And there are only 3 of the local authorities in North West London have submitted their Better Care Fund plans for this year to date. So there has yet again, and I'm really not happy to have to say it, damage been done to the relationship and the partnership between ourselves and the ICB round about the BCF. We had a 1.5 years ago about changes to how the above minimum contribution was to be moved around, and we've had it yet again. And we cannot have that a 3rd year running. And there is a little bit of lack of clarity about what the intention is for next financial year. So we're waiting to get that clarity, and we've been very clear that from the local authority perspective, Hounslow and our local authority partners, that needs to be absolutely clarified before we enter into our budget setting process for next financial year. We were meant to clarify the Better Care Fund financial envelope for this plan by July last year, and that slipped to not receiving the final documentation and the review until about 6 weeks before the submission date at the end of March. So we cannot have this happening again, because it does not help the relationship between us for these things to be coming at the last minute. But we have, as Martin said, successfully negotiated our way through. And I did brief you on the changes we've had to make and the schemes we've had to take out, but it is yet unclear what happens next financial year. So that needs to be bedded down fairly urgently.
Given what you've just said, Stephen, I mean, obviously I have been briefed, so I'm aware of this. Is there anything you think the board needs to do or support you on that, or myself?
I think if we're not in a position, here we are sitting in April, if we're not in a position by August, September for us, Martin and I, to clarify we're clear of what the financial position is, I think that does need to be a conversation between the Health and Wellbeing Board, the ICB and the local authority. We cannot continue on the way we've been doing it for the last 2 years. It needs to be planned. It cannot be reactive.
No, thank you, Stephen. And I agree with, I think it was a complex experience. I'm not going to get into the detail. I think going forward, Chair, we do need to make sure that we have full clarity on what the future of the ICB is, the future of NHS providers are. So I do think maybe the next agenda might need to be fully on that whole agenda, because there are big changes coming. I think it's important the Health and Wellbeing Board understands those changes, and within that, the future of the Better Care Fund. But there are lots of challenges that I think, now who we asked to attend, because I obviously represent the ICB in many ways, but I'm not an expert. So, but I think it's an area we really do need to focus on.
Okay. Sorry. Yeah, with that, we can make that, we can bring that outside the board, but obviously we can bring it in, yeah. So for the purposes of this item, we all agree? Yeah, okay. Thank you very much. I think that we're moving on to any other business, actually, and I haven't been told of any other business. Oh, Somebody put your hand up. Did you?
So I put my hand up. Yeah. Just the pharmaceutical needs assessment consultation ends on something like the 5th of May. It is really good that all board members complete it if you haven't. And if you haven't got a copy, Anne and Martha will circulate it to you all. But if you could complete it, that would be great. If you could encourage a few of your friends and other colleagues to complete it, the more information we get, the better it is.
Okay, thank you very much. Okay, in that case, I close the meeting and thank you very much for attending the Health and Wellbeing Board, and have a lovely evening, and see you at our next meeting, which is, I don't know when it is. Oh, 14th of July. Yeah, thank you very much. Good evening all.